Good morning, everyone. I will be presenting two abstracts in first-line setting for HER2 positive diseases. Before going on to my abstracts, because Cleopatra will form the baseline, I have just included a few slides on Cleopatra, where we all know that triple drug, dual anti-HER2 with a chemotherapy forms the backbone, has shown overall increase in progression-free survival and overall survival compared to just dual anti-HER2, single HER2 anti-HER2 therapy and docetaxel, where the progression-free survival in this trial was 12 months with anti-HER2 trastuzumab and docetaxel, but it increased to 18 months when combining second anti-HER2 therapy, that is pertuzumab, and overall survival increased by roughly 16 months from 40 months to 56 months in this trial, with obviously added toxicities of pertuzumab were diarrhea, rash, and pruritus, and muscle spasm, increased muscle spasm. But as both the arms had chemo backbone, there were toxicity of chemotherapy also, like neutropenia, nausea, and decreased appetite, and so on and so forth. Now, going on to my first abstract, which will try to say whether adding pyrotinib to chemo backbone, that is trastuzumab and docetaxel, is better than just giving docetaxel and trastuzumab. This is a study from China. It was started when pertuzumab was not a standard of care. So their standard arm is still only docetaxel and trastuzumab. So I have given the background already. The study design was, as we can think of, giving trastuzumab and docetaxel alone in the standard arm, in arm B, and in the experimental arm, they added pyrotinib 400 milligram per oral once a day to all patients who were HER2 positive with no prior chemotherapy in metastatic setting, 18 to 75 years of age and good performance status. They have excluded patient who had relapsed within 12 months of neoadjuvant therapy and those who had brain metastasis. They have accrued 590 patients with the primary endpoint of progression-free survival, same as Cleopatra, and a secondary endpoint of overall survival and others. Background, the patient background, you can see it is balanced in both the arms. Performance status was 0 in roughly 50% of the patient, and most of the patients were less than 65 years of age. Half of the patients were ER/PR positive, roughly in both the arms. Very less number of patients were FISH amplified. Majority of them were HER2 3 plus, and they were pre-treated because they did not include less than 12 months of DFI. So 12 to 24 months, only 10% of the patients, and more than 24 months were 33% of the patients. So progression-free survival in their trial is 10.4 months. We saw in Cleopatra it was roughly 12 months, and it increased to 18 months. Here it is 10 months, which increased to 24 months by adding pyrotinib to the doublet of docetaxel and trastuzumab. 12 months overall progression-free survival also seems to be estimated PFS is at 12 months is 44% in the experimental arm, at increase to 74% in by adding pyrotinib, and at 24 months also it seems that the combination drug is doing better than just giving docetaxel and trastuzumab. When independent review by the committee, in fact, the PFS did increase to 33 months, and the standard and the standard arm remained at 10.4 months. And the forest plot, as we know from Cleopatra study also, that patients who are not in visceral crisis, there may not add a third drug. Here also this is coming towards unity, otherwise most of the patients are going to away from the unity, and it seems that adding second anti-HER2 therapy, which in this case is TKI, seems to be better than adding than not giving it. Tumor response increased in the placebo arm, it was 71%, which increased to 83% by adding pyrotinib. Safety, as we know from the previous studies of pyrotinib, it increases diarrhea. So it was there in grade 3 diarrhea. All patients had, roughly all patients had diarrhea, but grade 3 were only in 46% of the patients, which was only 3% in the experimental, in the standard arm. And the diarrhea was there in roughly 8 day, median 8 day it started, but it lasted only for 1 day, and it was controlled by giving loperamide, which they allowed up to 16 milligram per day. And dose reduction was required in 1/4 of the patients compared to only 3% in the experimental standard arm. So one interesting fact that they have shown that they have found that PFS benefit was more by adding pyrotinib in patients who already had received trastuzumab than who did not receive trastuzumab. Something which was in Cleopatra was only 16 months in patient. It did not increase so much It was only 10.4 months in the standard arm, and in the experimental it was 16.9 months in patient who had received previously trastuzumab. But here it is not reached in the experimental arm compared to 9.3 months in the standard arm. So maybe in patients who already had trastuzumab resistance, adding TKI will overcome the resistance is what they have hypothesized, rather than adding second and monoclonal antibody. So they have shown that they have achieved their primary endpoint. Progression-free survival was better. It has manageable safety profile, as diarrhea could be controlled within 1 day with loperamide. It can be an alternative strategy to pertuzumab, but yes, we will have to wait for overall survival analysis. And it may overcome the trastuzumab resistance by adding a small TKI to trastuzumab backbone. Moving on to my second study. Second study is also in the same setting, where we are comparing TDM1 in elderly patients with the dual anti-HER2 therapy and backbone of docetaxel. We know Marian study where they tried to show whether TDM1 can replace trastuzumab and taxanes. There was very less amount of toxicity in the arm where TDM1 was given. As expected, it is an anti-ADC, which does not have much chemo side effect compared to what we will expect from chemo backbone. So they have hypothesized whether this TDM1 can be a non-inferior treatment for elderly patients who are more than 65 years of age compared to the standard triple drug therapy, with a primary endpoint of overall survival, secondary endpoint of progression-free survival, and others, where the good performance status were there if patient was more than 75 years old. If it was between 65 to 75, up to PS2 was also allowed. The median age of the patients was 71. Majority of patients were between 65 to 74 years of age. One third were more than 75 years of age. ECOG performance status was very good, 0 in 73% of the patients. Half of the patients were ERPR positive. De novo metastasis were 2/3 of the patients, and brain metastasis and visceral metastasis were also there. Brain metastasis was allowed in this case study. Overall survival has not been reached. The hazard ratio is 1.26 at present. In both the arms, it has not been reached. It has been present as an abstract in SABCS. Full paper is yet to come. They have what I found in the net is hazard ratio assumption was 1.35, but maybe it was wrong over there. That they wanted to say it was 1.25. So it has crossed 1.25. So they have said that it is a negative study and it is an inferior drug. TDM1 cannot be used. In case of progression-free survival, it has crossed, hazard ratio is crossed 1.35. Overall, the progression-free survival with TDM1 in first line is 11.3, but by combining it triple drug, it is 15.6 months. As expected, the toxicities with TDM1 were less. There was only thrombocytopenia or some transaminitis, or otherwise it was easily tolerable. The hypothesis was that maybe it is easily tolerable and it may be a non-inferior in the elderly subgroup. But TDM1 has failed to show non-inferiority compared to triple drug therapy in OS and PFS both. Adverse effect of grade 3 or more were frequent in chemo backbone, as we expected. Leukopenia, neutropenia, diarrhea, fatigue, and appetite loss were very common. And triple drug therapy still remains the standard of care even in the elderly patients. And detailed analysis will come once whole paper is there. Thank you.